Okay, I'm gonna broadcast in a moment here. So feel free to share the link. I've put the YouTube in the chat to everyone.
Yep.
And just a reminder, we'll wait like a couple minutes before getting started, so there'll be a delay.
Okay. All right, I just posted on Facebook and LinkedIn. I'll throw up on Twitter also.
Good morning, and happy birthday to Lieutenant Commander Jordan.
Good morning, everybody. Welcome on behalf of the African Global Mental Health Institute. I'm Michelle Durham, a psychiatrist at Boston University School of Medicine, and I'm happy to be co-moderating this webinar today with Dr. Banga Chaliza, chair of the department at the University of KwaZulu-Natal in Durban. Briefly, for those of us who are joining for the first time, the AGMHI's vision is to equip those in Africa and the diaspora with the tools and agency to effectively care for those suffering from mental illness by fostering collaborations, creating accessible training and education programs for both providers and the public, conducting and disseminating culturally relevant research, and identifying stakeholders to advance mental health care in Africa and the diaspora. I'm pleased today to be here with psychiatrists, physicians, and experts in mental health technology across the diaspora, from Kenya to Ghana to here in the US. Briefly, I'll give you bios of each and then we'll get right to it. Craig DeLarge is a digital healthcare strategist and mental health advocate at the Digital Mental Health Project, where he produces education, programs, and research, helping to improve the adoption of behavioral health services and therapies via digital technology. In his career as a digital and healthcare marketer, strategist, and educator, he's worked in world-class firms like Novo Nordisk, GlaxoSmithKline, and Merck. He holds a master's in business administration, is currently a graduate, currently a student of public health at King's College in London, and he's here in Philly. Dr. Edith Kwobo is a psychiatrist for the Department of Mental Health, Moi Teaching and Referral Hospital in Kenya, and we're happy to have her giving her perspective as a psychiatrist in Kenya, doing both research and clinical care. And then Dr. Atsu Lete is a physician and the CEO of Mind IT in Ghana, and very pleased to have him here today as well. We're going to start with Dr. Kwoba to give us a little bit of her background, also in the context of what's been happening in COVID-19 and using telehealth with the patients that she has been seeing.
Thank you very much, Michelle, and thank you everyone for creating time to be with us this afternoon for us and morning for others. And it's an exciting topic, the concept of telehealth. And like you asked, who am I? I'm a psychiatrist working in a referral hospital in Western Kenya. And mostly what I do first is administration. I'm a head of mental health department. I am also a clinician, so I see patients, run clinics. I teach students from different schools that rotate within the hospital where I work in. And more importantly, and what is very close to my heart, I work on some community projects to increase the accessibility of mental health care through capacity building of nurses and clinical officers to ensure that they can recognize mental health at the primary care level. And I'm also a member of the Kenya Psychiatric Association, where I actually work as the CPD coordinator, continuous professional education coordinator, among other things. And coming to work that we do, and then in the context of COVID-19, I was privileged to be part of the mental health and psychosocial support team of the COVID-19 Omoi Teaching and Referral Hospital. And part of what we did especially was train people on the mental health aspects. There was a lot of training on many things about COVID-19, but I was privileged to also include an aspect of mental health to ensure that people are taking care of themselves and they know what to do also when they are managing patients. So that was staff and the general public. And coming to the concept of telehealth, so prior to COVID-19, I'd say there was very little telehealth, telepsychiatry, teleconsultation in the context where I live. Patients would call once in a while, and as they talk to you, you know that they are consulting, because then the conversation would be a bit longer. And that would happen occasionally, but we were more used to a patient's booking an appointment even after they had told you their story and coming to the office for proper diagnosis, examination, and a hard copy prescription. Then COVID-19 happened, and unfortunately, in the context that is Kenya, one of the things that happened is that the rules to minimize spread of COVID-19 included an interference with the public transport system. And what that meant is that public vehicles had to transport less people because they needed to keep social distance, and the cost of traveling became even more expensive. And at that point, what we saw is people even calling a little more, and this time they'd be calling with a hope that you'll actually send them a prescription. So that's one thing that happened that was relatively new, so that a person would call from even as far as 300 kilometers, 500 kilometers, some you don't even know, and then make a phone call, and that call would last as long as a physical consultation would last. And at the end of that, then you'd send a prescription, mostly on WhatsApp. So we in Kenya, unfortunately, we don't have a very formal process of telepsychiatry. So what we improvised, because there's no formal process, is that after the patient calls you, then you do a prescription and send it to WhatsApp. Initially, it was actually a challenge because the pharmacists were not used to that. They're used to a hard copy prescription. And what I experienced is that initially, even the pharmacy where the drug would be picked, which is very far away from where I was, would call back and confirm that actually that I exist and that I have prescribed a certain drug. And as is the case for many countries, I believe most of the mental health drugs are actually prescription only. So that was a new experience. The other thing that we experienced during this COVID-19 season is that, like colleagues, around that time we were doing a lot of community education, and through the Kenya Psychiatric Association, we had started like a Tuesday meeting every Tuesday, which is continuing even up to now, to just educate healthcare workers about their mental wellness and sensitize them and support them. And one of the other things I experienced is colleagues actually calling, and they would call from very far, because usually the colleagues you'd see are the colleagues who are near you, and they'd call and you would take a walk. Sometimes I would take a walk and talk. And I remember we talked for like 1.5 hours, especially in the initial phases where there was a lot of anxiety. And you end up doing some form of supportive counseling, like crisis intervention on phone, which previously was not actually sort of accepted. It never used to happen. Most people would call and say, where can I book an appointment? Or where is the psychiatrist near me? But this time people knew even the psychiatrist near them might not be available. So phone calls is one of the things that we've seen increased people consulting and accepting WhatsApp prescriptions. The other important thing that I experienced for the first time, I had used Zoom prior because I work with quite a number of research collaborators outside the country. And one of the things that happened this season is that people had embraced Zoom because there were online classes. And I've had a couple of video calls on Zoom where I have consulted. I've consulted with some adults. I've consulted with children. It's been very exciting and very different because that was never happening. And the important thing is that this call would be scheduled. And it's very interesting that was possible. Of course, one of the interesting outcomes of that is that at the end of a number of Zoom sessions, someone would say, but I still hope to meet you one of these fine days. As if it gives you the impression that they don't feel like it is complete. So that was a very, very new experience. I didn't receive any email in terms of consultation, but at least the Zoom and the WhatsApp have been new ways we have explored. There was the WhatsApp video also, other than the WhatsApp texting and messaging and sending a prescription, there was also the WhatsApp video. That's really something that has come up. And like currently I'm also supporting some students who are like in Nairobi, and mostly they feel like they have met a psychiatrist, which is a very good thing. Although there are a few who feel like at the end of the day, when it's possible, they still want to meet you in person. I wonder whether they feel like it will be different. So that's one thing. So it's been an exciting journey, a new path that we've discovered that you really don't have to travel long distances. I believe it has cost even for them, but we also have a few challenges in the setting where we live in. One is that now that it's not a very formal process, people feel like they've just been chatting with you. And so for you as a psychiatrist, despite spending 1.5 hours or so to talk with a client, the compensation mechanism is not very clear. Actually, to be honest, most of those clients have not compensated for the time that I have spent. A few, especially when it was well scheduled, have sent some money on M-Pesa, and what they have done is not sent as they would have sent for a physical consultation. So I feel like that's a challenge, especially because you keep spending some time, but people don't feel like they should compensate you appropriately. The other important challenge in this part of the world is the issue of internet. We have quite some connectivity issues in some places, and therefore sometimes you'll be in the middle of the video conversation and the network just goes off, and someone has to either tell you they're going to buy credit or something like that to ensure that there's continuity or there's interruption so that it keeps hanging. So one of the things we've done is switch off the video, but even when you do the message, the voice, there will still maybe some interruption. And that is also a privilege, actually. As much as in Kenya, quite a number of people have phones, internet is quite expensive, even for those who can afford. And so if you're going to talk for anything 30 minutes, at least you require some, probably up to $20 or something like that to keep the conversation going, and that's not affordable for many people. So what has really worked well is the phone conversation, because the Safaricom, which is the main supplier of our data, offers some brief. You can buy a few minutes of voice, but for internet it's very expensive. So I think that's one of the things that we have experienced in terms of telehealth, some significant changes and experiences that we never had. And I believe that going forward, it will shape how people interact. The only hope is that somehow there can be a way of compensating the psychiatrists and other healthcare workers, because at the end of the day, it's time that you've spent, it's energy. And so I wonder whether the pro bono, the free consultation can continue for a very long time. Back to you, Michelle. I think that's what I'd like to see for starters.
Thank you so much. We really appreciate all your insights and clinical expertise as we're all dealing with the challenges of telehealth. And I appreciate you correcting me. Good afternoon to the other folks on the line. I only said good morning, so I want to welcome everybody again. Atsu Leti is a physician, and his program in telehealth, if you will, he'll describe a little bit of what he's doing, but was pre-COVID and when he was a medical student. So pretty inspiring in that, but I'll let you take it away and describe a little bit about what you've been doing.
Thank you very much, Michelle. Good day to everyone. My name is Dr. Atsu Leti. that I'm actually a doctor. I'm a houseman, currently doing my housemanship. The CEO of a mental health service called Minded Ghana. And I began this initiative when I was in State Health Medical School. Minded Ghana is a mental health service which seeks to screen people for mental illness or psychological distress free of charge and facilitate that they are having affordable and accessible mental health care. So we basically leverage on mobile phone technology. We began the service in 2017. It's about 4 years now. What we basically do is that we have that a short code, a toll-free short code with a mental health screening tool that's encoded onto it. So when people dial the code, we have a call center that will get back to them and then help them clinch that affordable and accessible mental health care. So we basically leverage on the community psychiatric clinics which are found in Ghana. So a nationwide service, which screen people and then signpost them so they can get affordable and accessible mental health care. Like as stated, we began pre-COVID era trying to bring mental health care closer to the Ghanaian population. And initially, telehealth wasn't much embraced in Ghana until the COVID pandemic began. It's something that many people can do it, or that COVID period is something that people have actually embraced so much, that telehealth, and it's really emphasized the need of Minded mental health service, seeing that the COVID alone can predispose a lot of people to mental health disorders. It becomes particularly important that we regularize our service and try to reach more people as possible. The onset of COVID, we try to expand to accommodate those who have mental disorders as a result of COVID as well. So its direction, I think, has been established as actually a opportunity what COVID is going to make in the parts of the country. Yes.
Atsu, I think we were having a little trouble hearing you, but are you pausing? Or are you finished?
Sure. Yes, I'll let me reconnect to you shortly.
We'll come right back to Atsu, and maybe we'll just let Craig go on. Here, Craig is based here in Philadelphia in the United States, and has done a lot of work in this sphere. And so if you can take us a little bit into the work you're doing and how it's impacting the mental health field from a technology perspective.
Yeah, so it's good to be here. I play a number of different roles within the mental health area. For many years, as you've already said, Dr. Durham, I had worked in the pharma industry as a digital health strategist, but also along my life track, I'd had a family tragedy related to severe mental illness, which pulled me into this space. So this is the reason why so much of my work is about understanding how we can better leverage digital technologies that we already own, whether it's a clinician in the clinic or whether it's we as consumers and family caregivers. How can we use technology to improve our resilience when it comes to stress, as well as how can we use it to improve our ability to recover when we are experiencing mental distress, disorder, or disability. And so I spend a lot of time doing research, understanding the emergence of different technologies, how they're being used. This is of a digital nature, and advising clinicians, companies, consumers, and caregivers, as well as healthcare systems and how they can best approach this. And then my wife and I, who work in this consulting practice, we also, on an ongoing basis, are developing educational programs, because we believe that while there's a lot of supply of technological solutions, we also see a pretty low adoption of these solutions Thus, there really is a need for education of both clinicians and consumers in helping to develop a level of understanding and comfort so that over time we get more adoption of very many technologies that have been developed for this space, where it's nice that we have the technologies, but we also have to be careful about a number of hazards that exist. We have to make sure that the technology in this application is effective. We have to make sure that it's safe, both in terms of the methodologies that are being used, but also data safety. And this is particularly an issue that we see here in the US and Europe, where we have a lot of regulation around these things. We also want to make sure, and I think this is something that's particularly relevant when it comes to our people, that stigma and discrimination does not become problematic when it comes to the use of these technologies. And we also have to make sure that we're not caught on the wrong side of what I'll call the digital divide. This is instances where we're not able to afford the technology, where we're not using appropriate technology. And this is where we talk about low to medium income communities or populations, and also situations where the technology is used, but not in a culturally appropriate or friendly manner. And so these are all barriers that I see in my research to how we can get more and better benefit from the use of technology that we have to be continually working on and making sure that we're addressing in how it's deployed. Thank you.
Thank you so much, Craig. Atsu, are you able to talk to us a little bit more now?
Yes, I am. Yes, I am. Thank you.
Sure. So if you can just, just to remind us again. So you've started a suicide hotline,
Yes.
and you said that you were using a code. Can you just explain that bit a little bit again to people that are on the webinar?
Sure. Good day to everyone. So I founded a service called Minded, and what we seek to do is we seek to screen we mainly wish to provide affordable, accessible mental health care to Ghanaians. So we basically have a tool for each short code. So it's a code *844 *555#. And then we have some screening tools on the short code, and it's free on all networks across the country. And then when people dial the code, they answer some 4 questions. We receive their responses, and then we call them and we help them get affordable and accessible mental health care. So we've basically partnered with the community mental health units, which are found across Ghana. So after screening the person, we just signpost the person to the nearest community mental health units. Yes, so our main goal is to provide affordable and accessible mental health care to Ghanaians. Yes, thank you.
Thank you so much, Atsu. And I think the question then I would want to ask you, perhaps I'll start with you, Atsu, and then I'll go to other members, is just a little bit about funding. I would imagine that these things, if the consumer, that the person that is using this doesn't pay for it, how have you gone about to try and get funding for the service?
Okay, so funding has been a main concern. So we initially began with contributions from our team. So we have a team of 5, and when we began, we actually contribute amongst ourselves to fund the service. But going forward, when we expanded the service a bit, we wanted to reach more people. We actually sought some funding, and we actually got some funding from some charitable organizations and individuals. So we got some funding for the first one, for the very first year, from some charitable organizations and individuals. So that's how we fund ourselves now. Yes.
And just maybe to give us a little bit of an idea about how expensive is the whole operation, do you have ideas on what the budgets, roughly, what the kind of the budgets are you looking at in US dollars?
Yes, so for a month, for our current operations, it costs, I would say just about $1,004. Yes, a little bit, about $1,400 to fund the service for a month. Yes, so about $1,400 to fund the service for a month. Yes.
Okay. So it sounds like it's something that's you are using a lot of using very little dollars and you're stretching it out, and it's great. I'm glad
Yes.
that you're able to do so much with such little money. I just want to move to Craig, and we'll come back to you, Atsu.
Sure.
Craig, I'm really interested in the whole issue of sort of education and stigma. One of this, as you know, in schizophrenia research, there's a lot that's written about how to help with stigma against people with mental illnesses, particularly with schizophrenia. And some of the research is showing that education of the population alone is not enough. It doesn't necessarily translate to lowering stigma or changing attitudes and, of course, behavior towards people with mental illness. So I wanted to ask you about how do we then, more than just educating people about the technology that we have, what else do we need to do to make sure that it is not as stigmatized as it is at the moment?
Yeah, this is a very good question. As a matter of fact, we actually see some research that shows that the more we educate, at least initially, stigma might increase for a while. So I have to tell you that I do see a generational trend towards less stigma as mental health has become more and more in the public eye. I'm amazed at the degree to which the students that I teach at university right now are more forthcoming and open when they're talking to me about the assistance that they need when it comes to depression or anxiety in the course of how I'm interacting with them in a course. I also believe that we need to continue to work on communications about mental health within our communities, not just from professionals, and how we need to talk about it as a community from the standpoint of prevention, not just something that we start to talk about and think about at the point of illness. And so I've seen an improvement. I think that continuing to use the channels that particularly young people are familiar with. So we see more and more case studies of how what I'll call psychoeducation is actually being administered through video games or, chat messaging and social media. And I think that as we continue to approach things in this manner, that as a function of generation, of a generational shift, that this is something that will change. I also see that we as caregivers, so I'll talk about myself now, as we become more the carers of our parents who unfortunately increasingly struggle with dementia and comorbid depression and anxiety that comes with that. Very often we are willing to let go of stigma and discrimination when a topic comes to our own household versus looking at it happening to somebody else across the way. And so I see both in myself and in my network, and I think we see more broadly in research, that as we come into a stage of life where we are more confronted with mental health challenges in our parents as they age, but also in our children as they struggle in society, that we also become more open to it. And then the technology just becomes a channel or a vehicle for education and communication that helps us along the way with that. So I hope you find that is a useful answer, but it's very challenging, very challenging.
Yeah, no, thanks, Craig. Yeah, I actually wanted to ask you as a follow-up question is that would one be able to use social media like WhatsApp, which is what we use a lot in South Africa to communicate as young people? So, I guess you're saying that, yes, the answer is you can use things like WhatsApp and all those kind of everyday type of, technology that we are using as tools for psychoeducation.
Oh, absolutely. Because understand that all channels and all communication, as we know, is an educational process. Whether we're talking about your math studies or where we're talking about the latest sneakers that you should be wearing or the music that you should be listening to. And so one of the phenomena we really have seen is that as more opinion leaders celebrities, government and political figures have come out and talked about their own struggles with mental health challenges and how they have normalized it, both from talking about how they've suffered, but also how they've recovered. This has begun to really change the complexion of stigma. Not that, and I don't think we'll ever get to a place where where is zero stigmatization, but the point is, can we get less than prior generations?
Sure, thank you so much, Craig. Edith, I just want to one question to you, and then I'll ask Michelle to start the Q&A session. Look at the Q&A questions and lead that. But Edith, just bringing back to as a clinician, and I think you've mentioned quite a bit about this. One of your roles is to try and educate nurses, and I think you call them clinical officers, in bettering the care of people out in the community, the psychiatric care. So I was wondering if there is a role, and whether you do this already, of telehealth in that space. So for example, if you have a nurse at a clinic very far away from Eldoret, if they're able to use WhatsApp video to chat to you, and perhaps with the permission of the client, if there's odd movements that the client is having, the nurse could kind of video that and show it to you. What's your experience around that kind of thing? So going from one provider to another, trying to use this telehealth as a channel to broaden the care that you're giving far away from Eldoret.
Yeah, so two things happened when we began to embrace telehealth. One is that we were meant to do trainings. In 2020, we also had scheduled trainings. And one of the things we realized is that we are not going to bring a group of people to one room, because usually we train more than 50 people in one room. So one of the things that happened is that even the training itself, for the first time, we had to do it on Zoom, which was very different from what we have done in the past. And then after we've trained these clinic officers and nurses, usually we'll send them, and the clinics where they run, where they see patients is very, very far away. And what we have seen is that sometimes even a patient would come with a prescription and they don't understand what that prescription is. And we've seen a lot of imaging that prescription and sending it to us and saying, this is what the patient is on. I've also seen at one point, I was consulting with one of the clinic officers, and I did feel like we were understanding each other. So what I did is we agreed that instead of him reporting to me what the patient is saying, that we can do a video conversation with the client using the clinical officer's phone, because we didn't want to burden the patient. So that's one other thing that we've been able to do. So yes, we've been able to support the clinic officers who are remote to do some form of a teleconsultation in instances where they are not able to send the patient. And what that has done is that it has saved the patient the need to travel over long distances. Of course, the patient, especially, there's one who was very paranoid, and I could hear the clinic officer encouraging him to talk to me. But you see, because it's a person who is far away, then they wondered, who is that person? What do they want to get from me? So that's one of the challenges, especially if it's a very paranoid person who is not very clear. These are the third party, and the clinic officer has really to go into details to explain that this is a consultant, they want the best for you. So that's one of the challenges. But yes, we've seen some improvements. Sometimes you even advise the clinic officer on a medication that they should give, and they probably are not getting it right. And so you just write it down and just send it to them. So we have been able to support them better, not just on phone. Previously, it was just a phone conversation, but we learned that there are many other ways of doing it after COVID happened. So it's been exciting being able to do that. But for me, the best thing is that we didn't have to hold our usual training, because we had budgeted and we had planned for the Zoom meetings, and we could even do the videos as they are doing role plays, which was very interesting and different from what we have always done. So of course, you always feel like, oh, is that okay? Or sometimes, especially when you're doing the trainings, some people have put off the video and you're not sure whether they're in the kitchen cooking or they're in the market. You really hope so. And at one point you tell them, guys, we need to all put our videos just to be sure that you can see them or encourage them to talk. But really, it's made a difference that we didn't have to stop. And what I believe is going to happen going forward is that we will, even when we have the opportunity to meet, we have learned that we can utilize the digital platforms. And you know what? Sometimes it's even cost saving because you just need data and them to sit in their house instead of me buying them a meal when I'm bringing them for training. So yeah, there have been positive gains in that regard. I hope I've answered your question.
Thank you.
Thank you, Edith. A few questions that have come through, sort of a twofold, and so I'll do two separate questions, but maybe Atsu can touch on this a little bit too, and then Craig. Around the education piece, because I am interested, Atsu, even in I realize that yours is, they dial a number and they call into someone, but is there an opportunity for people to get educated in that moment about sort of mental health and any type of psychoeducation sort of happening? And then Craig, I think, the question was also for you, because a lot of what you're doing too is around educating and decreasing stigma. So maybe Atsu, if you'd like to weigh in on that first.
Sure. Thanks. So as regards education, we do it in two folds actually. We have a separate education wing, that's education and advocacy wing, which is called Bear in Mind. So we have some animation videos which are there to sort of lessen the stigma about mental health conditions. We do hold some events occasionally. We once held as a debate in one of the universities in the country to help destigmatize mental health. So we just created an open forum for people to talk and discuss mental health. So we have one wing, which is that's aimed towards educating people about mental health. And also, when people dial the call, we have someone who would receive the call. So the call center operative. The call center operative has a background in psychology, and then he does some form of education before actually signposting the user to the nearest community mental health center. And sometimes he even goes the extent of educating the family members about what could be the person's condition. Yeah, so we do education in twofold, having a separate wing, and then with our call center operative actually educating the people and then providing some basic responses to their questions when he calls them. So that's how we do our education.
Thank you, Atsu. And Craig.
Yeah, and I'll piggyback on that. So appreciate, and I see the question that was asked in the Q&A. So my focus is not so much on education about mental health. There are tons of resources out there about that, but it's more about how to use the digital technology that we already have, right? That we carry around with us today, every day, in order to get more access to the educational content like what Atsu is developing, right? So people have devices that could get them access to information, but don't know how to use those devices to get that access. So we know that there are bunches of people that are working on developing the content. What we're trying to do is get people more educated about how to use the digital technology to get to that content and actually benefit from it. By the way, whether it's in the form of things that I read, watch, listen to, and I would say most importantly, getting access to peers that can support them in their mental health journey.
The other big question that's coming up, I think, in probably a couple different forms is essentially something that, Edith brought up earlier too, is this bandwidth and internet and access issue. And even, in a post-COVID era as well, how do we continue with some things that have worked? There are definitely folks that we do still need to see in person and that may want to come in person, but there may be other folks that want to engage in telehealth, but how do we, and this will probably be for anyone, Bonga included maybe, how do we start thinking about from that standpoint on the continent? I think we're having some of those challenges in the US, but I don't know if they're the same. But anyone that wants to sort of think about how do we scale up this adoption of telehealth, especially with some of the issues that Edith described as being on the ground from a clinical perspective and engaging with patients.
Yeah, I think, Michelle, it's interesting, and maybe let me start and say that certainly the psychiatrists in South Africa that are primarily in the private sector are the ones that have really adopted telemedicine and telehealth a lot quicker than the guys in the state sector. who are working with much sort of the communities are much more from the lower income groups. So even in the private sector, there are people that are saying in South Africa that they have adopted their practices into sort of hybrids. So they still want to see people face to face initially, and then perhaps as follow-ups, a lot of them are saying then that would work as a video. There's a lot of clients who are not keen to do videos, who really would prefer maybe a quick phone call if there's perhaps an issue of side effect to medication, for example, something quick that they can discuss with the psychiatrist, and they really would rather wait until the numbers of COVID are down and so that they can go and see their psychiatrist. So I think it depends on both the treating psychiatrist as well as the recipients or the clients of those services. And I think as we kind of develop this, it'll be really interesting to see how this ends. The other one, I think the other issue, I guess, is also about the physician's own sense of safety and how they approach COVID, this pandemic. I know that there's some psychiatrists who have been really a lot more afraid of COVID than others, and so have preferred to try and stay away and scale back face-to-face consultations as much as possible. And so I've tried to use technology as much as possible, and others are perhaps less afraid of COVID and are able to engage a lot more and become frontline workers. So I think it's a multitude of factors, and it'll be good to hear what others are doing. But I think that's some of the issues that we're having in South Africa.
Yes, so I'll speak up. So first, let me second everything that Wanga said, and then extend that to say that I believe that this idea of appropriate technology is really important. And what I mean by that is figuring out how to get mental and behavioral health interventions delivered effectively through whatever the technology is that a community has. So we know where there's high bandwidth, it's going to be video conferencing like what we're doing now. But there are very many communities where it's just going to be text messaging. And the fact is, in the digital health space, we've seen that, frankly, some of the most successful uses of technology in healthcare have been through text messaging, where you connect people with basic information, you give them the ability to perform important tasks related to their health, and most importantly, to be in community, because we know healthcare is social, and most of the effective change that's made is in a social context. You know, a lot of people look at the United States and think, oh, well, they have tons of bandwidth there. But one of the things that COVID has exposed for us as a nation is that not so. A very significant number of our citizens, and particularly, unfortunately, populations of color, have little or no internet bandwidth. And so even here, we're trying to figure out now how to work with and through that particular dilemma. I also like to talk, when this question comes up, about the work of Dr. Dixon Shabanga in Zimbabwe, the Friendship Bench, and how he actually had used the idea of educating grandmothers in cognitive behavioral therapy, and so that they can be a resource in much of a traditional manner to local communities, helping younger people with their mental and behavioral health. And so I think about how, even when the technology can't be used, say, as a direct intervention, how do we actually use technology to better educate a greater number of people within the community so that we have a greater sense of peer support? Once again, and particularly in communities where there are not as many professionals are not as close by, and where we have bandwidth challenges. So I like to say, where there's a will, there's a way. And again, the importance of literacy is getting us comfortable as communities with technology, but also being well connected and clear about the case studies that are working, and that can be further scaled. Thank you.
Yeah,
I think if I could just add in, just weigh in on the same issue. I find the government of Kenya using the mobile phones to send a message on different things that they find useful. And one of the hopes is that even going forward, especially if you think about sensitizing the public about the need to be to take care of their mental wellness, is that the government has a role to play to ensure that masses are getting information about their mental wellness. So that's the one thing I see going forward, so that people can see on their mobile phone. Sometimes I see when we had very many road traffic accidents, and you'd see a message by the government of Kenya saying you need to drive safely or don't drink while driving. And I think I'm hoping that going forward, the government can take advantage of the mobile technology and sort of send messages regarding mental wellness. But the other important thing is that, especially I see the data providers once in a while give offers for different things. Let's say if you're watching, there's football and World Cup is being played, and you see there's a subsidized data specific so that you can be able to watch football. And I'm hoping that there can be partnership between the mental health care providers and these data providers, so that once in a while then we can have data that allows people to either seek more information about mental health or to talk to someone, just something that's very specific to mental health. So that I feel like there's need for partnership between government and these big companies that really sell data, so that they can be able to provide subsidized sort of data that can enable someone get mental health access. I think that's the one thing I see, because I think as individuals, we are limited. I'd like to reach as many people as I could, but I'm limited. But the government has very many resources, and I'm excited about Kenya, the direction we are moving. The government has really made some positive steps in terms of mental health, and I feel like it's our role to keep being visible, so that as they invest in reducing road traffic accidents, they can also invest in doing something for mental health through the digital technology. Because we know up to 80% of the Kenyans have a mobile phone. So you can imagine if every so often a message was sent about depression and how it looks like, and that help is available. And after some time you talk about suicide, I believe so many people will be reached. So I feel there's hope, but I feel like there's also a lot of work for we, the healthcare providers in mental health, to convince the government that we are worth some investment.
Sure. Thank you so much, Edith. There's a couple of questions, and I want us to move to this about issue of security. And there's a few questions on the Q&A about security. So, Edith, as a clinician, perhaps we can start with you. But one of the things that obviously that we talk a lot about in South Africa is the issues of prescriptions. So if I see my client, on the video, and then they need medication, one needs to get a prescription to them. In our country, we haven't really adopted electronic prescriptions. When we do that, pharmacists are still up in arms, or perhaps are in the, I don't know, they're about 10 years behind us, because they all want these paper, patients must bring paper, particularly if it's a medication that is, it's got something to do with psychiatry, that say, oh, the Schedule 7, so it's very important that we get the actual original script from a psychiatrist. We don't trust these scanned or faxed or emailed kind of prescriptions. I was just wondering what your thoughts are and what your experiences are in Kenya, if they are a little bit more embracing of that. I heard you talk about WhatsApp prescriptions, and I thought, sure, that would be probably a step too far for some South African pharmacy groups.
Yeah, so there's that concern, and personally have been called by a pharmacy that says they want to know who am I. I always wonder whether they're able to open the internet and confirm, because Kenya has the list of doctors who practice in Kenya. So you can hear the questions they are asking, who are you, where are you practicing, that there's some fear. But what I have done is written. It's not digital quite, because it's really, I actually write the prescription using the hard copy prescription book from my hospital. I sign and write the phone number there for confirmation. So we're also not there yet, where we can do a truly digital prescription, and maybe with a digital signature. We aren't there yet. So what we are doing is a lot of handwriting, and then you take an image of that, because then to some extent, anyone would want to confirm whether that's my signature, as opposed to the e-signature, which maybe someone could possibly copy. So I am hoping that we'll develop to the extent that we can do e-signature. I remember there's a guy who was trying to develop an app for doctors. This was not mental health only, it was many doctors. And there was a possibility of you doing some e-signature and an e-prescription. But unfortunately, it was not well embraced. Even the patients themselves, the pharmacists, and even the doctors, some of them were a bit hesitant to utilize it. But given what COVID has shown to us, that things can change and we don't have to do things the way we did them previously. After all, even a hard copy prescription, someone can nearly fake your signature. For example, if there is a patient of yours or a staff who has an idea of how your signature looks like, they could easily do that. So I think going forward, we need to be more trusting and know that it's not true that hard copy things can't be faked. And so we should be able to embrace and move with the times, that probably the time has come where we need to change the way we do things and get over the paranoia of people faking things on our behalf. After all, I'm not sure how many people in the world are really interested in writing a prescription, maybe of Benzexo because it's addictive. But for many other drugs, I'm not sure that there are so many people who really want to steal my signature and write that prescription.
Sure. Are there any other, Michelle, I guess in Boston, you guys have embraced electronic prescriptions a long time ago. I don't know if there's any points that you wanted to mention from your side about these electronics signatures and things like that.
Yeah, I mean, it's not really something new to the COVID era for us. I think we've been doing it at least in our hospital. Every system is different, so I can only that's the unfortunate part about healthcare in the U.S. So even in Massachusetts, every hospital has a different system. So speaking specifically just from the hospital I work at, we've been doing electronic prescriptions for a long time. The new thing in the last few years is that we started being able to do more scheduled drugs as well, like stimulant medication, benzos. Those can also be electronic, and historically they weren't. So like 5 years ago at this hospital, they were not, but in the last few years we could do it as well. There's a whole, you use your phone, I'm on our electronic medical record. I put it in, I put a code in, then it goes to my phone and I have to say, yes, that's me who wrote the script. So it's all highly digital. If you don't have your phone, or if you ever get a new smartphone, you have to go through the process again to make sure they verify it through the hospital. The particular app that we're using called Imprivata. Someone had asked the question too around, I think we touched on it a little bit, but I'll just speak from our point of view of text messaging to patients. There's also another platform for that the hospital has asked us to use if we're going to text message, not even patients, but also other physicians, and we're going to use medical record number or patient's name or date of birth or anything that links the patient who you're talking about. It's called Haiku. So that's the platform that we have to use for those sorts of messaging, even within the hospital system, but if it's about a patient or patient care. So there are a lot of things, but I have to say, I guess the difficulty in all of this is that, I think in the US at least, you have to, anytime you go to a new system, it's something new to learn. And to Craig's point, specifically here at Boston Medical Center, we treat predominantly Black and Brown communities that are at or below the federal poverty line in the US. So they're struggling financially right now, especially right now. And they don't have access to the internet at the same, like someone else that could down the street, even in a place like Boston. So we're having some similar challenges with connectivity for some of our patients that just don't have the same access that other more affluent neighborhoods do in the area. I wanted to maybe a couple more questions, but there's a lot of different questions that are here. But one, maybe Atsu, just speaking specifically about, you developed something pre-COVID, and now we're in COVID, but there was one just in general about, technology and how do we scale it up? And sort of what would the needs be, even in your country, to scale up your particular platform? What would that look like? What would the investment look like? And are you even thinking about going beyond what you've done in Ghana?
Sure. Thank you very much. So As regards scaling our mental health service, we actually thought about that, and then we've made some plans towards that. At the moment, because we fund ourselves from donations from charitable organizations and individuals, we try to be as efficient as possible. So we leverage on already existing systems in the country. For example, as regards the community health centers, we actually don't pay the nurses. The mental health officers are on the government's payroll. So we just signpost people to them. We have a short code which is nationwide, that's free on all networks in the country as well. So scaling will require that we have more call center operators. So we'll have to recruit more people into our call center. And as regards that, the government has a national service program where you can have psychology graduates actually work in the call center. So these graduates can actually be given some training on how to screen people and how to receive the calls. And these graduates are paid by the government of Ghana. So we are actually planning on recruiting more psychology graduates to serve in our call center in the coming year. Scaling again will require that. So more graduates will require that would mean that we'll have to expand our call center. We'll have to acquire some more logistics for that, some computers, some mobile handsets for that. And this would actually increase our operational budgets. That's pretty much to about, let me say, $2,000 a month here. So that's one thing that we look forward to doing. Should we get any grants available? Sure, we'll apply to them and then we'll see what we can do. So scaling will mainly require that we increase our human resource because the systems are already in place to actually scale. So the core of scaling is our human resource capacity. Yes, that's a chunk, that's a crux of what we need to actually scale. Yes.
Thank you, Atsu. So I'm kind of pivoting a little bit and thinking about, there's a question around asynchronous live chats and in a therapy sort of model. And so I'm curious if any of that is happening. Does anyone on the panel know? And then maybe Craig knows a little bit from your point of view and your space that you're working in, a little bit about that. But is that actually happening on the continent? Someone asked in Kenya and Ghana specifically, what are you thinking about therapy being delivered in this sort of way? Does Edith or Atsu, do you know?
Yes, so for therapy, I know that that during the COVID area, most therapists actually went online to provide therapy via Zoom calls. So something that was being done in most of the major psychiatric clinics in the country, especially those in the capital and the southern part. Yes, we had many psychologists actually doing their therapies via Zoom calls, and it was pretty much effective. Yes, it was very effective from what I learned. It was very effective. That's the little I know about that. Yeah.
Yeah, and I think even in Kenya, I know quite a number of psychologists who are offering therapy on using the digital platforms. But what I know from the close friends is that unfortunately, the consistency of follow-up, because of the data, the things that we talked about and the bandwidth, then there's quite some interruption that's But the other issue I mentioned is about compensation, so that it's clear that we are going to talk on phone and there should have been a mechanism of compensation. And I have two friends who are concerned that, you see, if you came to my office, there's a secretary and you're able to pay, for example, and that is sorted and I don't have to handle. But now I'm the one who's talking to you, and most of these interactions, unfortunately, are happening through the therapist directly. And people don't honor that, and so they don't follow up. So yes, it's happening. And for a few clients, there has been good progress because then they're able to keep the part of their bargain, and the therapist was able to schedule them. But there have also been some hitches. And generally, I think therapy is not greatly like embraced even in our country. Even just in person, there's still that it's just talking. Is talking going to help me? And most of the patients don't follow up with the 12 or so CPT sessions required. It's now a bit more difficult, and now you expect them to continue talking on video or on voice. But yes, it's been embraced therapy sessions.
Craig, can you shed some light on that too?
Yes, I just wanted to do a kind of follow up on the last comment. And Michelle, you'll agree with me here. by what I'm about to say. So it takes a great deal of persistence and patience and hopefulness to bring about change in healthcare. And some would say it should, because we're dealing with life and death. But when you reflect on how long we have worked here in the West on doing research, building health economics cases, working with policy developers to get to the point where we now are getting reimbursement for telehealth, some people look at that and go, but it took so long. But the fact is, yes, it took a long time, but we've gotten there and we're going to get further. So I just want to note this as someone who worked in industry many, many years as a change manager, that, this can get done. We have to be deliberate. We have to understand it's a marathon and not become discouraged because it doesn't happen quickly. And the beauty of this kind of forum that we're having right now is that we can look at countries and economies where the cases have been built, a lot of times based on, and I know this will sound cynical, not so much a health outcome, but an economic outcome. But we live in a world where that's often what governments need to hear in order to be willing to make the investment. But the people who benefit from us getting savvy at coming up with those logics and those business and economic models, they're benefiting from it. So I just want to say that in the way of encouragement, because we can get into this thing of, it's going to take so long, this is never going to happen, I'll just walk away. We cannot afford to walk away for those that we're trying to benefit. So I'll leave it at that, because I can get on the soapbox about this at times.
Yeah, I mean, I would agree that change does take a long time, and I'm sure a lot of people could agree with that. There's another question that I think is very valid, and especially as someone clinically practicing in the US and in a system that we see lots of immigrant and refugee population here at Boston Medical Center specifically. And it's this element of thinking about cultural adaptation. And I would probably push that a little bit to also thinking about digital literacy and health literacy. And it's very different for like each individual that walks into the room of a clinical encounter and sort of where we meet them along the way. And so are there, I think, Atsu and Craig can probably touch on this a little bit too. How difficult was that at the adoption of your particular, thinking about suicide is a big taboo, I think anywhere, and people that are super religious, even here in the US, are very much like, you don't even think about it, much less go and talk about it. And so I'm just curious as from that cultural adaptation, have you seen from when you started this to now, have people been a little bit more willing to talk about it? And is there anything you think you've done differently than maybe another country would do based on where you are in Ghana, and that you would sort of advice you would give if someone wanted to take what you've developed into another country? How would some adaptations need to be made?
Sure. So as you rightly said, there's so much superstition and then religion attached to mental health issues almost everywhere. But what we noticed is that we found people who had been suffering from or were exhibiting some suicidal behavior for a very long time, probably for the past 2 years or the past 3 years. They attempted suicide many times. They felt adamant to confide in someone because of the fear of getting stigmatized. So our platform came in as very handy because it's an anonymous service. You just dial the code and then somebody calls you. The person either sees you, the person only hears your voice. So they felt very comfortable interacting with us, because as compared with going to confide in someone and then the whole stigma starts all over again. So they felt very comfortable confiding in us. And then we did give them some, I'll just call it some form of talk therapy on the phone before signposting them. So the anonymity factor really encouraged many people to dial the code because they knew that we were only going to receive their phone number. Some of them actually gave, should I say, incognito names. You didn't have to give your real name, maybe a letter would do, or whatever name you like us to call you by. So they felt very comfortable talking about their suicidal ideation and suicidal behavior to us. I think that our system is quite universal and then can be adapted to other settings in Africa because there's no, should I say, religious or superstitious component to it. And then it ensures some form of anonymity to a very large extent. We observe that people actually have a lot of problems they want to talk about, but then they really have no one to talk about. They don't want to be seen. Okay, I'll feel comfortable talking to someone over the phone. The person cannot see me. The person doesn't know my real name. So I think it's something that can actually be adapted in many parts of Africa where there's some huge stigma attached to mental health disorders, especially with the issue of suicide. Yes. That's what I think.
Thank you.
And yeah, if anyone is interested in replicating it, we are willing to help in that regards.
That's wonderful.
Thank you.
Craig, are you aware or working on any or aware of any sort of culturally appropriate thinking about the community and who's going to be using the particular product?
Yeah, so there's some good research and case studies of how we can continue to better leverage what I'm going to call community institutions. So, you know, here in the United States, and I believe the same is the case in Africa, is the church is really big. And the church has been a friend, but also a challenger of many advancements. I mean, my father's a pastor, so I see this firsthand. But I can tell you that in the advocacy work that I've done here in the U.S. with the National Alliance on Mental Illness, we actually have actively gone into communities of faith, sat down and talked with pastors, priests, rabbis, imams, to help them to understand the impact of mental health challenges in their congregation and how they can be prepared to address this issue in their congregation without alienating or violating their religious traditions. And what we found is that when this message of destigmatization comes from someone inside the community versus being seen as something that's coming from outside, that it gets traction and it begins to become a part of what I'll call the internal culture. And it's transformative. And so this can work. The other thing I'll tell you is that we're seeing a subsegment of the digital mental health space that is what I call indigenized or accultured. So for instance, we've got hurdle.co here in the US, which is a platform that's focused on delivering telemental health to populations of color. We've also got Ayana Therapy, another such platform. I know in the UK, I've seen digital mental health platforms that are focused on the Muslim community. And so we are seeing a whole founder community, I'll call it, that's really taking the importance of a cultured content delivered through digital channels very seriously. Frankly, it's happening in the Asian community also. So I'll leave it at that, but there are things happening, definitely.
So Michelle, I just wanted to ask you, as one of the closing comments from my side is I think that I really was intrigued by what's happening in Boston Medical Center and where you are around sort of using technology, for example, specific platforms to communicate with other clinicians or providers and communicate with patients. And I'm just wondering about the issue of sort of ownership of the data. I know that in South Africa, you know, there are some large medical insurances who, and in fact, hospital groups who in the private sector who are really keen on getting doctors to use their platforms. But then, of course, there's a whole lot of issues, ethical issues around sort of then who has access to that data, how often you connect with that particular client, you know, what happens to sort of issues around, you know, access to that data by third parties. And I'm just wondering if what your experience is there. I suppose that's also something that one would have to be careful as we go into this sort of digital or telehealth space.
Yeah, I don't know if I can directly answer your question. I assume the hospital has some type of cloud storage that all of these messages are, which is why they funneled it in all to one platform. Like we have a certain device we have to use on our phone, and right, and we have a certain device we have to use even if we're home. Now that there's a lot of remote work happening, you have to go through the VPN, right? Like so there are certain platforms we have to funnel everything through. So I assume all that data is getting stored there. Sort of email messages and things that we may, like patients may reach out in a certain way to us as well. All of that is through the electronic medical record. And even if someone does email me on my hospital email, the patient chooses to do that, there's still a place where I can, obviously that data is all secure too, because it's my hospital email account. But also there's a place even in our electronic medical record where it says, how did you receive this particular message? And you put phone, text, or email, and you can like copy it into the EMR. So there's also a discussion, someone brought up around privacy and laws. And what we've just been told from a provider standpoint is that any communication, and what we have to tell patients too, is any communication is part of your record. That's sort of the guideline that we have, so that they understand from the very beginning that, whether it's email or their patient portal that they send messages through, or voicemail messages too, like we will put all of that into your chart in the electronic medical record. So those are things that are discussed early on when you start treatment with someone. And that's just part of the policy and what we sort of all as providers have been told that we need to do. And so I think we've been doing it for so long too, even pre-COVID, that people understand that. And even now through outpatient clinical work, we're using the portal through the medical record. It's called Visual. That's what the hospital decided to use. I go into my electronic medical record and I click a button and the patient is already there. They get a message on their side that your appointment's at 2. And so I may be late, but they're waiting for me, and we click, and that's where it's all at. So it's all through the EMR. And this is to Craig's point that, COVID may change come very quickly, even for our health system, because we were not doing telehealth at our hospital. There were very few clinics who were sort of piloting telehealth via video. And essentially what happened over the last, now we're going to be a year next month doing this, but essentially the first 7 or 8 months, we were using a couple of different platforms that the hospital said we have to do something, so use it. But in literally 8 months, they came up with this Visual. It's linked now in Epic. And so we do also know the power of putting great minds together and what happens in a crisis, that things can get done quickly as well. With the right investments. And so we were 8 months in, and about, we started using this other platform that's connected to our EMR. And that would have never happened likely without, unfortunately, this pandemic.
So I just this will take less than 30 seconds to Michelle's point. It's very important to stay tuned to what we call the precipitating crisis, right? So in any environment, the powers that be were always talking about what can't happen until there's a precipitating crisis. So we know here in the US that for more than a decade, we have been trying to convince the government to reimburse telehealth at a level that would make sense. And it was always, no, we can't, this, that, and the other. When COVID happened, In a 2-week period, the government came out with an order that now all of a sudden, all of these platforms that we used to not be able to use, just go ahead and use them because we need to serve people in this crisis, and we'll sort out the details of it later. And it opened up a floodgate now that can't be closed. But my point is, the precipitating crisis is really important to kind of frame stories for policyholders in government where they see that, oh, this is something we really do have to do. The society, the economy is going to suffer. And we get those stories communicated at a critical mass, then we get change faster than we expected.
Excellent closing remarks. Thank you all for a wonderful panel today and for doing Atsu and Edith. Thank you so much for sharing everything you're doing and all the good work that's happening on the continent. Craig, your expertise in this space was really well received. We have lots of more work to do, but we also know with a crisis that we can make this work happen. So we keep moving forward. I hope you all have a wonderful rest of your day. And we'll be sending out announcements about our next webinar, but we're really happy that you could all attend today. Be well.
Thank you
so much. Take care.
Bye.